Hey everyone, welcome to another episode of What the Dementia by Bambu Care. I'm your host, Brianna Wilson. I'm a certified dementia practitioner and the founder of Bambu Care. So today we're doing another podcast episode on a rare form of dementia. If you haven't already and you're interested, be sure to check out the last rare form of dementia that we covered back in February. And that one was on Creutzfeldt-Jakob disease, okay? So, anytime that we talk about any type or form of dementia, I like to start off with what dementia actually is, and that's just because I want everybody to be on the same page, okay? So, dementia is this big umbrella term to define a collection of symptoms that affect memory, thinking, behavior, and emotion, even language, in a way that significantly impacts daily functioning. And these symptoms can be caused by a number of different diseases or conditions, okay? So, for today's podcast episode, we are going to be talking about Huntington's disease. Before we get going, though, I did want to remind you all that we have a free webinar coming up on Tuesday, March 28th at 7:30 p.m. Central Standard Time called Dementia Communication 101 Understanding Effective Communication Strategies, and there will be a replay available. So, even if you cannot make it live, please be sure to register. Registration ends this week on Saturday, I believe, so you don't want to miss it, okay? The link to sign up will be in the podcast notes, okay? Also, if you enjoy our podcast episodes, please be sure to give us a good rating to help other dementia care partners like yourself find our podcast, okay? It would be so helpful and I would be so grateful. If you would like to keep up with us between episodes, consider following us on Instagram at Let's Bamboo or joining us in our free support community at letsbamboo.com/champions, okay? So let's go ahead and get into Huntington's disease, which you may hear me refer as just Huntington's, okay? But Huntington's is a hereditary neurodegenerative brain disease, and it was named after the person who first described it, which was George Huntington back in the 1800s, okay? Now, as you may know, most types of dementias are not genetic, but this one is and it's pretty rare, affecting about 1 in every 10 to 20,000 Americans, okay? Now, Huntington's disease is caused by a single defective gene on chromosome 4, and it has an autosomal dominant pattern of inheritance, meaning that it only takes one single copy of the mutated gene for the disease to manifest. And they actually didn't identify this specific gene until 1993, so only like 29-30 years ago, okay? Now, Huntington's disease typically starts between the ages of 30 and 50, but it can begin much younger. There's been cases starting as young as like 2 and as old as like in the 80s, okay? Now, the youngest person that I worked with that had Huntington's was like in her late 20s. I want to say she was about 28, but I don't remember how old she was when she was first diagnosed, okay? Now, if a person is diagnosed before the age of 20, then it's considered juvenile or early onset Huntington's, and it does tend to progress more rapidly with a survival of less than 15 years, okay? Whereas people with symptom onset after 20 have an average lifespan of about 10 to 25 years, but some people have lived much longer, like 40 years even, okay? But one thing that is important to know is that there is no cure for Huntington's disease, and so treatment is typically focused on symptom management and quality of life, okay? So let's talk about some of the symptoms. So the number one hallmark symptom is chorea or choreiform movements, which are like involuntary jerky movements of the arms, legs, and or face, okay? Then we have bradykinesia, which is slowness of movement. Dystonia, which is this sudden contraction of a muscle, and it often causes like a twisting motion from the muscle contraction. And so all of these things, the chorea, the bradykinesia, the dystonia, does put them at an increased risk for falls and injuries. And though their early motor symptoms may start pretty mild, as their disease progresses, all their fine motor and gross motor coordination skills will become impacted and in a very significant way, okay? Other symptoms include memory loss, poor attention and concentration, speech impairments like trouble articulating words, especially as voluntary control of their lips, tongue, and mouth decline, and eventually their ability to coordinate speaking and breathing will decline, as well as their ability to coordinate breathing and swallowing, okay? They will also typically have sleep problems like insomnia or waking up frequently during the night. They'll have changes in sexual interest, especially a lack of interest in sex, which is the most common, but also increased interest in some cases as well. And then also difficulty having sex due to the involuntary movements, as well as erectile dysfunction and things like that. And then also, they frequently experience neurobehavioral symptoms like apathy, depression, anxiety, irritability, impulsivity, and obsessive compulsive behaviors. And because these symptoms can be pretty moderate to even severe, it's often recommended for the person's neurologist to work in coordination with a psychiatrist or psychologist for better care of the person living with Huntington's, okay? Now, I do want to say that with juvenile Huntington's, chorea, the hallmark symptom that I mentioned, is less prominent in most cases and may even be absent altogether. And then some people with juvenile form do experience seizures, which is not that typical of people with regular Huntington's, those who are diagnosed or have symptom onset after the age of 20, okay? So let's quickly talk about how Huntington's disease is diagnosed. Now, most dementias require a pretty involved rule out process, and with Huntington's disease, when early symptoms are present, or maybe the person has juvenile Huntington's disease, or maybe the more psychiatric or neurobehavioral symptoms pre manifest Huntington's, there is more of a rule out process that has to happen, and it can be mistaken for other conditions. But if that hallmark symptom of chorea is present, then it's typically not as difficult to diagnose, okay? So when it comes to diagnosis, there are three main things that they're looking for, okay? One is the chorea or the choreiform movements. Two is family history, as again, it is genetic. Now, in some cases, they do have a hard time finding family history, especially if the person who had Huntington's died or passed away before their symptoms were ever able to express, okay? And then another thing that they look at is any other supportive symptoms indicating a decline in function or onset of mood disturbance. And then it may be confirmed by a genetic test because if that person has the abnormal gene on chromosome 4, then the doctor knows that that person will have Huntington's disease at some point. But the doctor will have to figure out if the symptoms they are seeing are in fact related to Huntington's disease or if something else may be going on. Okay? And then lastly, I just want to quickly outline 4 special things that you should know regarding Huntington's, okay? And I will be briefly mentioning suicide, okay? But it will be the very last thing, and so I'll be sure to give you a trigger warning right before I start talking about it, okay? So, number one of the things that I want to outline is pain, because people with Huntington's disease are at an increased risk for pain. And this is for several reasons. So, for example, severe chorea, dystonia, contractures, or rigidity, all those things can cause pain. They can be experiencing pain from accidents and falls, like sprains and fractures. Pain from pressure sores, either from immobility, especially in the later stages, or from those repetitive movements that they have causing friction and thus skin breakdown. And then constipation or urinary retention, okay? Now, here's the thing, because they are often unable to recognize or report their pain, their pain may go untreated. So it's important to look towards those nonverbals and behavioral changes and let the physician know so that they can do their own assessment and so that the pain can be adequately managed, okay? The second thing that I want to talk about is medications. It is so important to know that people with Huntington's can be particularly vulnerable to medication side effects, especially cognitive side effects, but other side effects as well, okay? So, for example, medications that are often started in like the early to mid stages of Huntington's to manage that hallmark symptom of chorea may actually exacerbate other symptoms like rigidity and bradykinesia in the later stages and actually result in delirium or oversedation as well, okay? So it's going to be particularly important for you to monitor medication side effects and report any concerns to the doctor, okay? And just because they've been fine on a medication for years even doesn't mean that that medication can't start causing issues later, okay? The third thing that I want to talk about is weight loss. Weight loss in the mid to late stages of Huntington's is pretty common, and they think this is because the metabolic rates are higher in people with Huntington's and those constant movements from chorea and dystonia do take a lot of energy. And so, in order to combat this, people living with Huntington's usually require a higher caloric intake to maintain their weight, which can be difficult, especially as it progresses, because then swallowing difficulties becomes the thing as well, okay? And then the fourth and final thing that I want to talk about, which here is my trigger warning, is suicide. So, unfortunately, people with Huntington's disease are at an increased risk for suicide. People with any type of dementia are typically at an increased risk, okay? However, it has been found that about 10% of people with Huntington's specifically will commit suicide, and 50% have experienced suicidal thoughts at some point, okay? And the risk seems to be the highest in the mid stages as their symptoms increase and their independence decreases. And as I mentioned before, neurobehavioral symptoms are frequently experienced by this population as well, with some reports of hearing voices berating them or urging them to commit suicide, or they may be having delusions about a certain scenario that make suicide seem like the best option. So it's kind of compounding, okay? So the doctor should be regularly reassessing your person's risk for suicide, okay? And you too should check on how your partner is feeling in a very nonchalant but caring way, asking them how they're feeling and if they still feel like they have something to live for and are enjoying at least some things in their life, okay? You don't have to bring up the word suicide if that's not something you're comfortable doing, or if you don't think that your partner would respond well to that, okay? But you definitely want to let the doctor know if you have any concerns. And you can even text or call 988, which is a suicide and crisis lifeline, if you are really concerned and you want help or advice in the moment, okay? And I'm not sure if there's an international equivalent to the 988 number or if this number works internationally as well, okay? But those are the four things that I wanted to be sure to mention before I wrapped up this podcast episode. I do hope that you found this podcast episode interesting and informative. Again, if you did find our podcast helpful, please consider leaving us a review to help others find the podcast. If anyone has any questions, comments, or future podcast requests, remember that you can send us an email at podcast@whatthedementia.com. Thank you so much for joining us on another episode of What the Dementia by Bambu Care. We look forward to catching you on the next episode. Take care, and until next time, stay strong, care on, and remember, you are not alone. Bambu Care is always here.